Good morning. If you are using CPAP or APAP, this video is it for you. Have you ever started CPAP or APAP and felt like I can breathe in but I cannot breathe out comfortably? This is what something called EPR setting in your machine may help. But there's a catch. In some patient, using the wrong EPR setting can actually make treatment less effective. Many sleep apnea patients are started on APAP, 5 to 15 centimeter of water with humidification, and they are told just use it and you'll get used to it. But what if the pressure feels uncomfortable, and especially when breathing out? Should EPR be turned on? And if yes, when? EPR can make CPAP much more comfortable, but in the wrong situation, it can lower the pressure too much and allow the airway to collapse again. So in this video, I will explain exactly what EPR is, what it does, and who benefits from it, and when it should be used carefully. Hello everyone, I'm Dr. PK. So EPR means expiratory pressure relief. This is especially important for patients who are set up on APAP, 5 to 15 centimeter of water with humidification, because many people use this kind of setting in the beginning. But then a very common question comes up: should EPR be turned on? Who really needs it? And when can it actually create problem instead of helping? Let's break this down in a very simple language. What is EPR? EPR means expiratory pressure relief. That simply means the machine reduces the pressure a little bit when you are breathing out. So it does not feel suffocating and difficult. So if the machine is giving a certain pressure when you breathe in, it can lower the pressure during exhalation to make breathing out feel easier and more natural. Think of it like this: breathing in with APAP pressure is usually easier for most of the people, and that pressure is needed to keep the airway open. But breathing out against a pressure can sometimes feel suffocating, uncomfortable, especially if you're new to CPAP or APAP, you're not used to it, right? And it can cause claustrophobia and people quit using a machine. So it just becomes useless. The whole purpose is defeated. EPR is meant to improve comfort during exhalation. Now, on many PAP machine, particularly the ResMed had that machine has a setting EPR1, EPR2, EPR3. This usually means the machine lowers exhalation pressure about 1 centimeter of water, 2 centimeter of water, 3 centimeter water. So higher the EPR setting, the easier it may feel to breathe out. But there is a problem with that. We're going to talk about that, how high you can go. Why does EPR help some patient? Here's a big reason. Some patients say the pressure feels too strong. I feel like I'm fighting the machine. I can breathe in, but I have trouble breathing out. I feel air is being pushed at me too hard. I remove the mask because it feels uncomfortable. So for those patients, EPR can be a major comfort feature, and comfort matters a lot, because the best CPAP setting in the world is useless if the patient cannot tolerate the machine and stops using it. Defeats the whole purpose. So that is very important point, right? A patient does not fail CPAP. Sometimes CPAP fails the patient because the comfort setting were not optimized. What does EPR actually do to treatment pressure? This is the question you have to remember. What does EPR actually do to treatment pressure? This is the part many patients, even some providers, do not fully understand. EPR improves comfort by lowering pressure during exhalation. But that also means it lowers the effective expiratory pressure that is helping keep the airway open, right? Because there's a pressure difference that has to be maintained to keep the airway open. And that really matters because in obstructive sleep apnea, when the upper airway is collapsing during sleep, certain amount of pressure has to be maintained to keep it splinted and open. And so if your EPR is high, you can basically deduct that pressure and see how much is your effective pressure is going in. So if EPR lowers the pressure too much, some patient may become more comfortable, but the airway may also become less protected and will start collapsing. And so that is the trade-off. Comfort improves, but airway support during exhalation may decrease. So that's where the problem comes in. Finding the right balance is very important. And that's when your compliance data comes to help you decide what kind of changes you have to make. I'm not going to give you an example. Let's say a patient is started on APAP minimum of 5, APAP maximum of 15, humidification is on, ramp is on, EPR is added. Now suppose the pressure is sitting around 5 or 6 early in the night. And if EPR is set to 3, then during exhalation, pressure can drop by 3 because EPR is set to 3, right? That means the effective pressure during breathing out may become quite low because if the minimum pressure is set to 5, if you deduct by 3 because EPR is set to 3, and then the pressure becomes, residual pressure is what, 2? But the most of the machine, the minimum pressure set is about 4 centimeter of water. So suppose even 4 centimeter of water, it may not be enough to keep the airway open the way you intend it to be. This is why EPR is not just about comfort setting. It is a comfort setting with treatment consequences. A patient may say, this feels much better, but their airway may actually be getting less support, means less opened than they need. They may start having snoring and having tiredness and sleepiness because their sleep apnea is not completely eliminated because EPR pressure is too high, although they feel good because it's comfortable, it's making their exhalation comfortable. So that's a trade-off. Which patients are more likely to benefit from EPR? EPR is really most helpful in patients who have pressure intolerance. This includes new CPAP or APAP users, anxious patient who feel claustrophobic, people who say exhaling feels hard, patient who awaken when pressure rises, people who keep removing masks because of pressure discomfort. It can also help people who are very sensitive to pressure changes and need the machine to feel more natural. So the main reason to use EPR is not body size alone. The main reason is, does this patient need exhalation comfort to tolerate PAP therapy? That is the real question. Does body habitus matter? Well, that's a very smart clinical question. The answer is body habitus can matter indirectly, but it does not decide EPR by itself. I'll give you an example. A patient with a high BMI, chubby patient, large neck circumference, more severe airway collapse, REM-related or supine predominant obstructive sleep apnea, they may need a stronger airway support. So if you give high EPR and keep the minimum APAP pressure too low, the airway may not stay open at all because the effective pressure is less to keep the airway open. On the other hand, some thinner patients are extremely pressure sensitive and may tolerate PAP much better if EPR is used. So habitus alone does not determine whether EPR is needed. The better way to think about it is this. Patient more likely to need caution with the EPR. They are obese patient, severe sleep apnea, supine, OSA, marked snoring, persistent hypopnea, if you see in compliance report, significant flow limitation, and high collapsibility airway. Patients more likely to benefit from EPR are those who have pressure intolerance, anxiety with PAP, difficulty relaxing, and poor adherence because of comfort issues. So EPR is really about balancing comfort and airway control. When should EPR be used? EPR is reasonable when the patient feels uncomfortable breathing out, patient struggles to fall asleep because of pressure, patient keeps taking off mask, patient says the pressure feels strong, PAP use is poor because comfort is poor. In this situation, EPR can improve tolerance and improve nightly use, and better nightly use often means better long-term treatment success. And you have to use it cautiously if patient has persistent obstructive apnea, persistent hypopnea, snoring despite therapy, significant flow limitation, and has very slow starting minimum pressure, possible treatment emergent central apnea, or severe OSA requiring strong expiratory splinting pressure. Because in this situation, reducing the exhalation pressure too much can make airway control worse. So finding that balance sometimes can be difficult. When should EPR be avoided or minimized? So EPR may need to be minimized or reduced if residual AHI in your compliance data remains high, or obstructive events continue. That simply means that EPR is lowering the effective pressure to keep airway open. So, but thing is that if EPR is 3, you can go down to 2 or maybe go down to 1 and check it in a month or so with the compliance data, see what numbers look like. It should be avoided and minimized in people with residual AHI is high, obstructive sleep apnea continues, snoring continues, flow limitation continues, and if the patient's minimum pressure is too low. If you are starting in just the 5 and that's the lowest setting, and starting EPR with 2 or 3 is a bad idea. Maybe you should just start with the 1 and see if that's good enough or not. So thing is that you cannot trade comfort and make sleep apnea worse. So this trade-off is not going to help in long term. Sometimes patients feel better with high EPR because breathing out feels easier. But if the residual obstructive events go up as indicated in your compliance data, then treatment may actually be less effective. So we do not judge EPR only by comfort, we also judge it by result. If it is not doing the job it's supposed to be doing, then it's not really a good thing. What is central apnea? It's another key caution. If the patient begins to show central apnea or treatment emergent central sleep apnea, then setting needs to be reviewed carefully. EPR is not automatically forbidden, but you have to be cautious. And some machines, they will tell you if the patient is having central sleep apnea. If breathing becomes unstable or pressure changes affect ventilation, then central events may persist and become more noticeable. So when central apnea keeps showing up, this is not the time to casually keep increasing EPR without reviewing the data. So what is the practical way to start EPR? For many patients, APAP practical approach is to start slow, improve comfort gradually, review treatment response, download your data from app. All these machines have an app, you can download it. And start with EPR 1. Start with the lowest, and if needed, move to EPR 2. EPR 3 is only clearly indicated in situations where you see the residual EHI is still high. Otherwise, there is no need to go to put everybody on EPR 3. So don't put automatically everybody on EPR 3. Start with the EPR 1. Because the stronger the EPR, there will be more reduction in exhalation pressure. So there's a less splinting pressure available to keep the airway open. So important issue with APAP 5 to 15 plus EPR. Here's one of the biggest practical lessons. If your minimum pressure is only 5 and your EPR is set high, the effective expiratory pressure may become too low for many OSA patients. This is especially true in obese patient, moderate to severe OSA, patient with REM-related worsening, supine sleepers, patient with snoring and flow limitation. So sometimes the problem is not that EPR is wrong. The problem is that minimum pressure is too low for the amount of EPR being used. So in that case, you got to change the setting from 5 to 15 to maybe 7 to 15, 7 to 16, something like that. One of the most common mistakes in PAP setup is this: turning up comfort setting without making sure the airway still has enough pressure support to stay open. So clinical principle to remember is this: if you increase EPR, you may also need to increase the minimum pressure, because you need that pressure differential to keep the airway open. For example, if someone truly benefits from EPR 2 or 3, but the airway is still collapsing, then leaving minimum pressure at 5 does not make sense. And that does not mean every patient needs a higher minimum pressure, but it does mean the setting must be interpreted together. You should not think of a ramp or minimum pressure, maximum pressure, humidification, and EPR as separate, unrelated features. They all work together. What about ramp? Ramp is another comfort setting. Ramp starts the pressure lower and then gradually increases it over time, often over 5 minutes or so. That helps some patient fall asleep more comfortably. But if patient has severe sleep apnea and sleep onset obstruction and rapid sleep transition, immediate airway collapse when falling asleep, then too much ramp plus too much EPR plus low minimum pressure can make treatment weak early in the night. So comfort settings are helpful, but they should not weaken the therapy too much. Humidification is very important. It is used for comfort because this machine called dryness, nasal irritation, mouth dryness, nasal congestion, and humidification very helps. Humidification helps airway moisture and comfort. EPR helps exhalation comfort, but both can improve tolerance, but only EPR directly changes expiratory pressure. So in simple summary, let's make this very simple. EPR is good for making escalation easier, improving comfort, helping new users adapt, helping anxious or pressure sensitive patients, improving PAP adherence. EPR can cause problem if minimum pressure is too low. Residual obstructive events remain present and snoring continues. Flow limitation continues. Severe OSA needs stronger airway support. Central events are appearing. Body habitus does not alone decide EPR. It's more about pressure intolerance, severity of obstruction, airway collapsibility, residual data, comfort versus effectiveness. You don't want to trade up too much for comfort in favor of comfort to effectiveness. So if patient is started on APAP 5 to 15 with humidification, EPR can be helpful, but it should not be treated like a one-size-fits-all setting. Patient who cannot exhale comfortably may do much better with EPR, but a patient with a severe obstruction and low minimum pressure may actually need careful adjustment because high EPR can reduce the pressure too much during exhalation and will help collapsibility of upper airway. So the best APAP setup is not most comfortable setup alone, but it is not the highest pressure alone either. The best PAP setup is the one that gives good comfort, good adherence, good control of obstructive events. That's the main reason you are using the machine. Stable breathing and restful sleep. So if you are using CPAP or APAP and still feel uncomfortable, do not assume you have failed treatment. Sometimes the issue is simply the setting that you optimize. And if you're a clinician or provider, remember the CPR is a comfort tool, but it must always be balanced against airway control. If you found this video helpful, please like, subscribe, ask any questions, share with someone who uses CPAP, APAP, and it still struggles with the pressure setting. I'm Dr. PK. I'll see you in the next video. One of the common problems is that there are lots of sleep lab out there, and they do not sit down with the patient and explain to patient in details what these numbers are, what they mean, and it's kind of frustrating. It's really frustrating, and some people get so frustrated that they end up not using CPAP machine. I usually in my clinic sit down with the patient, make them understand the basics so that they understand that this is not something it can be good in the very beginning. It takes time to understand and make adjustment back and forth to find that optimal pressure. When you reach at this point, everything becomes very good. So thank you for watching TGIF.